If we talk about endoscopic decompression, endoscopic disc surgery, we should know what we are talking about. Endoscopic spine surgery does not mean endoscopic spine surgery. First, there's an inside-out technique, there's an outside-in technique, there's a full endoscopic technique, there's a particularly endoscopic technique. And dear Mr. Loy, you forgot Thomas Hoagland. I think he is one of the main endoscopic spine surgeons in the field, and I think he has changed in the last century, not last century, but in the last 10 years, a lot of about thinking how to treat herniated discs in spine, and so we have to think about it. Okay, I will tell you something about my clinical results and also about the limitation of the transforaminal endoscopic decompression and removal of disc herniations. And the other one is the interlaminar procedure. I personally do not like the interlaminar procedure because, as in the literature we can find, the risk to have a dural leakage with the dural leakage complication is much higher than through the transforaminal approach. So that's the reason that I always try to do everything what is possible transforaminal. What was at first the purpose of the study was to evaluate the effectiveness and complication rate of a transforaminal endoscopic nucleotomy for lumbar radiculopathy independent of size, location of the NPP or spinal anatomy. What was the selection? Persisting sciatica, positive rising leg, failure of conservative therapy, numbness or loss of strength in the leg, positive MRI or CT, or OP in only one level. Exclusion criteria for the study: herniations in more than one level, previous operated disc, patients younger than 18 and older than 65 years. Over 500 patients have been operated endoscopically in a time period of 16 months. 264 patients fulfilled these criteria I have talked to you about previously. The follow-up was 2 years, and the follow-up rate was almost 96%. 30% of my patients were female and almost 70% male. The average age was 42 years. The main levels I have operated was L5S1 and 4-5. Let me start first with the complication. It is not that if we talk about endoscopic procedures, that we do not have complications or risk or problems. 2 patients showed an increase of the leg pain after the endoscopic procedure. 1 patient reported an increase of this numbness. 2 patients were further treated with a catheter. 1 patient was fused. 6 patients showed an early recurrent disc herniation. That means within 3 months. And I personally think that I did not remove all the herniated disc material, so I think it is a surgery or a surgeon's failure. At 2 years, all were very satisfied or satisfied after second surgery. No wound infection. I had for sure irritation of the dura, but no leakage complication with the transfemoral endoscopic procedure. How is it with the recurrence rate? 12 patients were treated for recurrent disc herniation between 3 months and 2 years. All over recurrence rate was 4.7%. The average interval between the first and second operation, I can report, was 184 days. 8 times in L5S1, 4 times L4-5. 9 were very satisfied or satisfied after the endoscopic recurrent reoperation. 1 patient, unfortunately, has unchanged, and 2 worse after 2 years. If we look to the patient's own satisfaction, I can report that an excellent or good result I could find in 96.4%. If we compare now to the microscopic, open, classical, still worldwide golden standard procedure, I think a surgeon with a good experience who made a lot of disc operation has also the same result. It is like Sang Ho Lee has told you, at least all I'm reporting right now, it's a question of your experience you may have, okay? The only, from my point of view, the big advantage in endoscopic spine procedure is you do not need in general anesthesia, and you have a much, much faster recovery of your patients, and you do not have problems with scars, dural leakage, bleedings, infections, etc. If you look to the leg numbers before the operation, so I can report that 90% had no leg numbness anymore, or it was much improved. For loosening of the strength in the leg, almost 94% did report, 60% was not present anymore, and 34% has reported it is much better. For the McNabb criteria, an excellent or good result I could find in almost 94%. For back pain, if you look to the visual analog rate or scale, there was an improvement from 8.5 to down 1.9, and for the leg pain from 8.3 to 1.7. Now, let me give you some examples. Sure, I'm standing here, and I can report that I did more than 6,500 cases already. And what is the possibility and limitation of the transforaminal decompression? First, let me say, any kind of disc herniation in lumbar spine independent of size, location, and the presence of high iliac crest, or foraminal stenosis or central spinal stenosis, or disc herniation in thoracic spine lower than TH6 can be endoscopically be treated. But if we talk about it, for that at least you need to have and you need to use a reamer or a burr. This is an easy level. Let me give you some examples. Here you see a disc herniation, level 5-6, 5S1, and down you see the X-ray control. That I always try, if I do the endoscopic procedure, I remove the disc herniation. The disc herniation has optically, visually fitting to the MRI picture. What do I expect? I always try to see the freed pumping nerve root, and I always do my intraoperative X-ray control to see that my tip of my forceps is fitting exactly at the spot I would like to be. Here you see L5S1 approach, transforaminal in the female, and again the control of the forceps. Here you see already a slight foraminal stenosis. Unfortunately, I do not have a pointer, but at 4-5 you may see the big processus articularis superior, and it is particularly narrowing the foramen. And here on this picture, you see the patient, same patient with a disc herniation that I have performed additionally foraminectomy, or let me say a foraminoplasty. I think Martin Knight will explain what is the difference, and will give also a talk about it. Here you will see a far caudal sequestrated disc herniation in 4-5, almost sitting and fitting in the recessus, and I do not come from the contralateral side. I come always from the same side, from the ipsilateral side. It is just a question of the approach, and that you have maybe to remove particularly nothing of the facet joint. For that deep, it is not necessary yet. But what I ream is always only the outer part of the processus articularis superior. That means I do not destroy and I do not affect the facet joint. And that is the reason that I do not have problems with that. Here you see, at least normally in a very easy case, an intraforaminal disc herniation at level 3-4. Here you see the control of my forceps, and that time I performed always before additionally a discography. And here now you see the video. It was very nice. The operation went very fast. From running from 11 to, let me say, 12 o'clock, you see the exiting nerve root, and the disc herniation is compressing the disc, the nerve root. And now you see how I can remove the extruded disc herniation, as you all know. A different example, for example, very seldom, maybe I did 2 or 3 cases in my life, but a far posterior or dorsal secreted disc herniation. You can't do it transfemoral, because if you do it transfemoral, you will fail, okay, because it's posterior. So for that, I used an interlaminar approach. As you may see here, the distance from the midline is maybe 2 or 3 centimeters, and all these procedures I do under fluoroscopic control, and at least if I have brought in my working tube, I bring in also my endoscope, and under endoscopic control, again you see the X-ray control, I remove the disc herniation, and here you see the control, and the MRI is exactly fitting to the intraoperative forceps. Now you see here a male patient with a high iliac crest. I have operated in a meeting with the company of Trimax, I think it's 3 or 4 years ago. It was in Munich, and my first patient was a male patient with a cranial sequestrated disc herniation in level L5S1. And behind me there was a bed that I can't remove the disc herniation. But I did, and not transiliac. I will show you this picture. This is a male with a high iliac crest. If you have a disc herniation on spine level, that means your approach has a little bit more steep. If you have a cranial sequestrated disc herniation, like in this case in 3-4, that means your approach is more parallel to the disc level and not that more cranial or steep over the disc, ahead the disc level. This is also an easy case of disc prolapse in L5S1, again with an example of the fitting of my forceps. I think you will agree with me. Here you will see typical freed pumping nerve root. I don't know why the video is not running. This is a typical view in the beginning. You see some red soft tissue, maybe from the flarum and disc herniation, then you remove it. And in an optimal running procedure, you see the freed nerve root like you have seen in the beginning. Oh, okay. Okay, this is a perfect picture. If you have removed the amount of tissue you expect, if you have made the control, the X-ray control of your forceps, and if you see this freed pumping nerve root, the procedure is done. Again, nothing for a transfemoral procedure. This is a dorsal cyst. The dorsal cyst also has to be treated interlaminar. Here's again an example of the positioning of my forceps. This is a typical picture. If you come from the interlaminar approach, I do it also carefully, not to have any complication in reason of dura leakages. Additionally, I used also a laser, a side fire laser. I like it for this kind of procedures. You can shrink soft tissue. With bone, it's a little more difficult. For that, I use the reamer and the burrs. And I think this is the case, a cranial sequestrated disc herniation. I do it also transfemoral. I make no hole into the iliac crest. I don't like to do it like that, but it is possible. As you see, again, here's the control of my forceps, and I will bring down the MRI to the X-ray control. Okay. And here again, the approach. Sure, in L5S1 with a high iliac crest, your approach is not that lateral. It is more medial, and I agree with you. I have to take more bone from the facet joint, but I did not destroy, and I do not destroy the facet joint. It's always a question of the anatomy. Again, here, this behind vertebral body L5 herniated disc. It is cranial sequestrated or it's caudal sequestrated. Unfortunately, I do not have the other MRIs. It was a far caudal sequestrated disc herniation. For this kind of disc herniation, I remove particularly again, of the processus articularis superior, of the lateral part, and part of the pedicle, to come at least to reach this spot and not to come to the opposite side. And here you see the X-ray control of my forceps. Also in this case, I could remove this far caudal sequestrated disc herniation. And on the picture in the left corner, again, you see the freed nerve root. I am very happy with this big disc herniation, and not my secretary, but my nurse. She was also wondering what I have done. Here you see spondylolisthesis, elytic spondylolisthesis, degree 2 with a big disc herniation, lateral disc herniation. I think if you would have done it open, I think I would bet more than 60% of you would have fused the patient. Maybe all of you have fused the patient. If you do it with a transfemoral approach and endoscopically, it's not necessary. Here again, you see the control of my forceps. Even in thoracic spine, unfortunately, I have only one picture. You can remove it. The distance is very low, not to puncture the lung. But you're limited to, in my opinion, you're limited to level 5, 6 in reason of bone and of the shoulder. Again, here the steps I have done with the dilatator in the beginning. You should pass the medial pedicular line, because in thoracic spine there is something what we call medulla, and we shouldn't damage anything, but you can do it. This disc herniation is a little bit complicated, but it's maybe you don't see it in the beginning. Why it was complicated? Because as you see on the right MRI picture, you see the S1 root on the lateral recessus. And normally, if we talk about disc herniations, the disc herniation is compressing even the transversal nerve root by side, and from the side you can come and you can remove it. So I decided to come from more cranial, from more, not exactly the lower Cambin triangle. I tried to come, as you see with my X-ray control, from more cranial. And then I had this bended flexible forceps from Joymax, and I could remove this nice disc herniation. It was a little bit tricky, and I was proud I could get it. Even it's published by Thomas Hoagland and me. I think in 2008 we published that we reoperated 256 patients who underwent an open microscopic disc operation. Even endoscopically, it is a very nice tool to do it again. You do not have to pass the old scars and the old approach from the previous open operation. You do not have to pass again. And I think this will be one of the last pictures. It was a colleague from Denmark. He came by the ambulance airplane, and this patient, she had a drop foot, as you see here, with intraforaminal disc herniation and compressing the L5 nerve rod. And here again, there you see the pictures before the operation and the picture below after the operation. I have nicely removed the drop foot. It was real drop foot. It was 0 of 5. And after operation, at least it was 1 or 2 of 5. But she sent me an email and she developed fine, and now she's almost 3 or 4 or 5. So what is the limitations of the transforaminal endoscopic discectomy? Like I told you, and I showed you the pictures, a dorsal posterior sequestrated disc herniations. In my opinion, is central stenosis. You can do it interlaminar, no problem. I think Mr. Rutten will talk about it. Large cyst is also no indication for transforaminal endoscopic procedure, and disc herniations higher in thoracic spines than TH6. That means, in a conclusion, for me, the transfemoral endoscopic discectomy and decompression is an effective and safe procedure without significant complications compared to an open microdiscectomy, independent of size, location of the herniated disc, and in our center, already the golden standard. And I still hope, if we all see us in 2 years again, it will come the gold standard, the endoscopic procedure.
Yes.
Thank you for your attention.